What role can community pharmacies play in reducing deaths from bowel cancer?
Bowel cancer is the second biggest cancer killer in the UK, responsible for more than 46 deaths every day.
Millions of pounds are being invested in the challenge to develop cures for bowel cancer, and incremental improvements are being made.
However, there is one way we can reduce cancer deaths right now, irrespective of new drugs. That is to improve our early detection rates, finding more of the cancers at an early stage.
If bowel cancer, or colorectal cancer as it is known, is detected at stage 1, it has a high cure rate, more than 90%. Those diagnosed with advanced cancer, or stage 4, have only a 10% survival rate.
My name is Stephen Rowley, and bowel cancer detection is an important topic for me. I went to the doctor with a symptom, blood in the toilet. I thought it was piles. Well, I did have piles, but also had stage 3 bowel cancer, just below advanced stage 4. The treatment was harsh. No one likes a big operation, but the effects of the surgery were nothing compared to the impact of chemotherapy. Now, 9 years on, I live with long-lasting side effects, but I am here. I survived. My brother was diagnosed at stage 4 and died 6 months later. I know how important early detection is. Something I know now, but I did not know then, is that most common bowel cancers take more than 10 years to grow before they spread. This potentially provides a big window of opportunity to detect it at an early stage, when a cure could be achieved, and without the severe treatment I had to endure. I'm here in the Behavioural Research Department at University College London, where I've been working as a patient advocate on a research project to look at the role of community pharmacies in detecting bowel cancer. The work is funded by the National Institute for Health Research, and in collaboration with the pharmacy department in Newcastle University, this project is looking at the potential for community pharmacies to play a role in improving national early detection rates for bowel cancer. Christian von Wagner is Professor of Behavioural Science at University College London. He is joint lead investigator on a project to explore the potential role for community pharmacies in detecting bowel cancer early. Christian, what's this project trying to achieve?
Our project is trying to bring together community pharmacy staff, staff working in primary care, and members of the public to co-produce a set of practice guidelines and research recommendations for how community pharmacy can help facilitate the early diagnosis of bowel cancer.
Before diving into the details of how community pharmacies might do this, we perhaps need to understand more about early diagnosis. Willie Hamilton practiced as a GP for 25 years before he became the Professor of Primary Care Diagnostics at Exeter University. Willie, can you tell me the importance of early diagnosis in bowel cancer?
Thanks, Steve. It's important for two main reasons. The first one is the earlier you catch it, the smaller the cancer may be, and the better staging equates to better outcomes. The second reason to capture it early is you can capture bowel cancer before the patient gets complications. And these complications can occur as an emergency, requiring you to go to hospital immediately. And this complication and emergency brings a mortality of its own. Overall, the figure we use is about 1% better survival per week of expedited diagnosis. Now, 1% doesn't sound that much, but a week is quite a short time. A 4-week delay is 4% worse survival for that individual. And that's roughly the same amount of benefit that you get from all the chemotherapy after your cancer has been treated surgically.
So how does early diagnosis differ from screening?
Thanks, Steve. Well, screening is systematically testing a population, whether they've got symptoms or not. And screening with the fecal immunochemical testing identifies about 5% of the current cancers in this country. That leaves the 95% who present with symptoms and generally report it to their GP. But in this project, we're talking about whether they should be considering reporting it to the pharmacist as another entry route into healthcare. So the key difference is the patient has symptoms, And the symptomatic patient with colon cancer is currently about 95% of the cancer burden in this country.
Screening using a tiny sample of stool is remarkably effective at identifying bowel cancer before people might notice any symptoms, thereby catching the disease early before it has had time to spread. There are many thousands of people alive today who owe their survival to the National Screening Programme. Andrew Prentice is the Health Improvement Principal at St Mark's Bowel Cancer Screening Centre in London. Andrew, who is eligible for screening?
Okay, so everybody who's registered with the GP, currently the ages are age 54 to 74. By the end of this year, that will have lowered to 50. So everybody 50 to 74 who's, as I say, registered with the GP is eligible and will be invited every 2 years to take part in bowel screening.
Is the screening programme popular? Does everybody who's eligible take part in it?
No, unfortunately not. And that's part of what my role and what health promotion does in bowel screening is about increasing awareness. Currently, only about 50 to 60% of people that are invited take part. So we tend to find that there's a better uptake. It's about 60% with the 60 and above, but then it's been around for them a lot longer. And the younger age group, and it could be that one, they're not as aware, or secondly, they're of working age, so maybe not quite so easy to attend screening appointments. But actually, the initial part of the screening program, which is the home testing kit, can be done, in the privacy of your home. So fairly easy, really.
What do we know about the people who don't take part in screening?
I think there are a lot of barriers, for many different people. Different barriers for different people. I mean, some of the most common things that we find is that actually people think, well, I haven't got any symptoms, so I don't have anything to worry about, when in fact it's the opposite. So there's a bit of education to be done there about, this is for people that don't have symptoms, as I say, because one of the most common barriers we get is, well, I'm fine, so don't need to worry about that. The other one is, they automatically think, I'm not touching my poo. If doing this test kit, forget it, I'm not doing it. So again, it's about educating people that you don't need to. There's ways of doing the test and collecting your sample that you don't need to touch your poo.
Are there certain sectors of society who are less likely to take up screening?
There are, and I think it depends whether you look at the national data, and when you think about some of the larger metropolitan, very diverse cities, that can be quite different. I think national data says that people from Black African, Caribbean and Asian communities are less likely to take part. That may be the case at a national level, but I think you'll find in London that's not necessarily the case. We cover outer northwest London for St Mark's, and it's very, very ethnically diverse. And actually, we have a fairly even split between those that identify as white and those that come from other ethnic groups. We know that people from more socially deprived areas are less likely to take part in screening, and that if you think about it, it's that actually they've got so many other things to worry about that their health generally tends to come much further down the ladder to those immediate needs like putting food on the table or paying a mortgage or paying rent. So it's about making it as accessible as possible, and to do that you actually need to speak to those communities and find out what are the barriers for them. It's all very well us thinking, well, these are the barriers, but quite often they may be wrong. So you definitely have to work with those communities. And what we do at St Mark's, we do audits every year. So not only around who's coming for screening and breaking that down by demographics, ethnicity, gender, that sort of stuff, but particularly location. We also do what we call our colorectal cancer audit, where we look at anybody that's getting a colorectal cancer diagnosis by whatever pathway, be it A&E, GP referral, screening, to pick up those ones that aren't coming through screening. And when we, again, break that down by demographics, that gives us a really clear picture about actually who's not coming for screening, but actually who's getting colorectal cancer. And that allows us to set priorities about who we need to work with. Who we need to work with, is quite crucial, that we need to get involved those communities, to identify their own barriers and come up with solutions.
Against this backdrop of poor screening uptake in some areas and the challenges of low cancer symptom awareness, community pharmacies may provide an essential channel of opportunity. Back to Willie Hamilton again. What do you think the benefits are of involving community pharmacies in early diagnosis?
The crucial thing is to allow patients who've got symptoms of possible cancer to enter healthcare. There's been the traditional route of general practice. Other routes are just as important, and pharmacy is an untapped opportunity for some patients with symptoms who either can't get to see the GP or don't want to see the GP to enter healthcare by a different route. So the more the merrier, as far as I'm concerned.
Let us look at the research methodology employed in this project. For community pharmacies to play a role, they will have to find a particular niche within the whole early detection framework. Sanjana Challa is one of the researchers at Newcastle University. Sanjana, who are the various stakeholders and how have you engaged them?
So the various stakeholders that we engaged in our research work are members of the public, community pharmacists, and the GPs in London and in Newcastle. And in terms of engagement, we have conducted a series of 3 face-to-face workshops in London and in Newcastle. And in each workshop, we discussed 3 various questions which were in alignment with research objectives. And the questions were, how do we identify the individuals who are at the risk of colorectal cancer? What was the importance of raising awareness about colorectal cancer? And how can we signpost individuals with higher risk to appropriate services such as GP practices?
With so many stakeholder inputs, how do you make sense of all that information?
So we did gather a large data across the 6 workshops in total, and then we employed a qualitative analysis technique called nominal group technique. It's a combination of ranking the ideas and voting them according to what majority of the people felt were important to support the early diagnosis of cancer, colorectal cancer, and then we summarized them into top 6 themes. And the themes that we generated were as follows: improving communication and collaboration between healthcare professionals, raising awareness and public health campaigns, targeting those at risk and providing test kits, improving inclusion and accessibility for underserved communities, support, training, and education for pharmacists, pharmacists' role, environment, and their autonomy.
And so, Sanjana, how is this information being used?
So the themes that we have gathered across the series of 3 workshops, we have then conducted 2 dissemination workshops, one in London and in Newcastle. So the one in London, we discussed about how these ideas can be now put forward as research recommendations, or what kind of studies can we conduct around the ideas that we have gathered for future research purposes. And the dissemination workshop held in Newcastle, we discussed about how these ideas can be put in the form of practice guidelines, where community pharmacists can benefit to support early diagnosis of bowel cancer among individuals.
Shakira Holyfield is one of the researchers here in UCL in London. So Shakira, what kind of ideas and responses did these stakeholder workshops generate?
Well, we got quite a few different ideas from the workshops, some of which were things like placing pickup cards about colorectal symptoms on the edge of shelves that contain medication used to manage alarm symptoms such as loperamide and fibergel. Other ideas with things like pharmacy counter staff would need full training to be able to answer patients' questions accurately, otherwise confidence in the pharmacy would be compromised. Pharmacy staff should ask more about symptoms. For example, patients collecting iron tablets, pharmacists could ask them, have there been any changes in their bowel habits, unexplained weight loss, etc., and kind of just cover a range of the different symptoms. Something that was kind of expressed quite a lot throughout the different workshops was the importance of inclusion and accessibility in underserved communities. So one of the suggestions was that we could provide support and advice in multiple different languages, especially in socially deprived areas. And we got a lot of stuff around kind of collaboration between different healthcare professionals. So one of the ideas that came out of the workshops was that we could run clinics and special events in collaboration with GP staff, which would help with kind of spreading awareness and targeting those that are at higher risk.
So Dan Brunsden is a medical anthropologist here at UCL. With so many perspectives coming out of this research, how do you go about analysing such qualitative information?
Well, obviously as a co-production event, it's very important not to be overriding all of the input you've got from all of the stakeholders that have been brought together. by doing the qualitative research. So it was a bit of a tricky one, but we decided on a framework analysis. So we effectively took the outputs from each of the 2 workshops, the Newcastle ones and then the ones at UCL, and we used that as the basis to then code the transcripts into each of those 2 frameworks. The idea was really to kind of spot check the outputs of those workshops, so to kind of be a quality assurance arm of the study, but also to try and tease out why there were these differing priorities. So if there was a recommendation for a policy that was number 1 Newcastle, but number 2 in UCL, why is that? Maybe we can use the qualitative data to try and direct us more.
The important element of this approach is the participation of stakeholders, bringing together all of the people involved from pharmacies, screening and primary care and the general public to share their experience and identify opportunities. All through this research, we have to think about the individuals, the people that will benefit from engaging with early bowel cancer detection. Lindy Berkman is a patient representative with lived experience of colon cancer and has been actively involved in this research right from the start as a co-applicant. Lindy, can you tell us about the role of the patient representative in this type of research?
Given that it is very difficult for people to get GP appointments in this day and age, it's somehow crucial for them to be able to approach a pharmacy and be able to talk about symptoms and issues that might be worrying about them. And so the impact could and should hopefully be earlier diagnosis of bowel cancer.
Julia Owes-Dilley is the Associate Director for Transforming Cancer Services team for London. Julia, you've been taking part in these workshops. Are there any particular ideas that have really inspired you?
Yes, I think the groups that I've been sitting at, the things that we've been inspired by are the opportunities that pharmacists potentially can offer to identify people that have got at-risk colorectal cancer symptoms. But what we really need is the research and the evidence to inform this sort of work and to be able to mainstream it going forward. We need to really understand how many patients are actually coming into these pharmacies, you know, in urban areas, in rural areas, in sort of cities. We need to understand how the pathway would work, for example, how do we give people tests and how does that get recorded? And so we really need the research to inform what the pathway looks like and how viable it is to go forward. But a great opportunity, I think, and we were very inspired by this idea at the workshop.
Josephine Fagan is a retired GP from Newcastle with special interest in Crohn's and colitis and has been participating in these project workshops. Josephine, in order to make this work, what do you think needs to happen to improve the communications and collaboration between the community pharmacies and the GPs?
Well, currently, if a community pharmacist takes a history from a patient that's indicative of bowel cancer, that patient would need to access a diagnostic fit test rather than a screening fit test. And they may even require a 2-week wait, urgent suspected cancer referral. And I believe the quickest and safest pathway for these patients to be referred by the community pharmacist to the GP is to have protected slots on that GP's list. At the moment, 111, out of hours and paramedic services all have protected non-patient facing slots every day that they can use to book patients into directly. And I believe that community pharmacists should have the same.
Lalit Shah is a community pharmacist in central London. Lalit, you've been attending these workshops. What sort of things have inspired you about this research?
It's the knowledge, the information I gain out of all these workshops, which I can then pass on to my customers. I see customers coming in with all kinds of illnesses and symptoms. So attending something like this gives me a bit more information on the condition. And if I see somebody with similar symptoms, then I can recommend that they go see their GP.
And how do you think the sort of the guidelines and recommendations that have been discussed could be implemented in community pharmacies?
At the moment, the big drawback is remuneration. A lot of pharmacies or pharmacists are just paid basic salary. They do not get any extra for doing any other referral work. So if they were remunerated appropriately, then I think the take-up would be even higher.
Next, I talked to a group of pharmacists with a particular interest in the early diagnosis of cancer. Ziad Lakluk is the pharmacy integration lead for the early diagnosis of cancer pilot for NHS England. Wasim Bakir is a member of the pharmacy integration program for NHS England, and Ushin Kavanagh is a pharmacist at Newcastle University. First of all, Ziad, perhaps I can come to you. What do you see as the potential for the role for community pharmacies in early detection?
Thanks, Stephen. So really good, important question. I suppose, historically for community pharmacy, having, being in a position in their communities to, speak to people without necessarily having those people, registered or attached to a particular pharmacy. I think there's that kind of access element, which is quite useful historically in community pharmacy for people accessing all sorts of services, from, dispensing of medicines through to more kind of wider public health services, vaccinations, for example, and more recently, the expansion of clinical services. So we're seeing more for that's, for things like blood pressure checks and contraception, and now pharmacy first for certain common conditions. So what that means really in the context of early detection is, varied footfall has never been so good for community pharmacy, particularly with the expansion of services now. And so that present every interaction between a member of the public, a person, a patient, with any member of the pharmacy team presents an opportunity for the person to really talk about sometimes, for example, symptoms. So the person might come in and actually specifically mention that they have a symptom that they're concerned about. In the context of bowel cancer, those symptoms can be sometimes quite obvious, but sometimes they can be a little bit more subtle. And lots of kind of training campaigns before for pharmacists to supplement their existing training have really enabled them to pick up specific red flag symptoms in the context of, for example, bowel cancer. So they're well positioned as part of those conversations to ask specifically and kind of drill deeper into those symptoms to try and see, is this person potentially at risk? Do they have, what we would call a suspected red flag symptom that could be suggestive of cancer, or is it perhaps something that they can be reassured about? So that's kind of, I suppose, one scenario that could present, somebody coming in with a specific symptom. The other side, of course, is also people coming in with repeatedly purchasing specific medicines. So people buying, something for a gastrointestinal ailment. Again, the pharmacy will be well placed to see that person coming in at the counter. So it could be a counter staff, member of the counter staff. It could be the pharmacist themselves who gets to see that person coming in and repeatedly purchasing the same product, which again could be suggestive of a particular symptom, which could warrant a further discussion with the pharmacist. So actually, is there something else going on here? Or is this kind of just a common ailment that you're trying to treat with over-the-counter medication and not necessarily accessing further help through your GP or other healthcare professionals? So I think that kind of almost that informal walk-in relationship that people have with their community pharmacies across the country is really a massive opportunity to try and see if we can pick up and just increase that early detection in bowel cancer, but also a range of all sorts of other cancers that we're actually looking at in our wider pilot at NHS England, part of the pharmacy integration program, looking at a number of different red flags across different tumor sites that we think would sometimes be suggestive of something a little bit more sinister or not sometimes at times. I think that those are the kind of main key opportunities for community pharmacies that I see in the early detection of cancer.
Yeah, well, thank you, Ziad. Very, very well put there. Wasim, what about aspects of accessibility? Community pharmacies are often in areas where GP surgeries are not, and also in communities which are otherwise underserved.
That's right, Stephen. Research from Newcastle University has shown what we call the inverse care law. There are more community pharmacies in areas where there's less access to general practice and less access to primary care generally. So yes, they're usually located in higher areas of higher deprivation. And the other thing, the important thing about access is that a community pharmacy tends to employ people from their communities. So they tend to have people who speak the language of the community. And I don't just mean language as in English or other languages, but actually understand the culture of the community and understand the people who they serve. So that's really important, because when you're actually trying to detect red flags or sinister symptoms or medicines buying behaviour, like Ziad has said, you really need to understand some of the cultural things that are going on locally. So they are very well placed, and you know, sometimes there can be real differences across different streets in the same town. So it's a fantastic place for putting in programmes for early detection of cancer, and a great area to explore further in research.
Yeah. Oh, thank you. And Ushin, I know you're particularly concerned about that aspect of deprivation and the culture of deprivation.
Yes, I guess just to add on to some of the comments made by Wasim just now, you know, pharmacists and their teams are embedded within the communities, and they do often reflect the community, you know, with respect to the staff members that are in that pharmacy and speaking with patients every day. And as the pharmacist going into these different pharmacies, you know, in my past life as a locum, you might have seen some of the best teams, you know, had someone you could speak to and say, well, can you speak to this person? Well, oh, I know him, you know, I know him or her, and so on, and that sort of bridges the gap a little bit, you know, and allows you to engage more fully with the patient. You know, it's different than handing out a leaflet or whatever, you know. You know, sometimes people think about culture as a language, you know, Arabic and English, but maybe that's you know, the slang and, you know, Queen's English or Oxford English, you know, and how do we reach those people in those communities? Well, we need to speak in the same way they do, and try to communicate ideas in maybe the ways that they'll understand, and you know, they can embody going forward to make, you know, if it's a behavioural change or if it's to engage with a service or so on.
Andy Husband is head of the School of Pharmacy at Newcastle University and has been involved with the project since its inception. Andy, pharmacy is constantly evolving discipline. How do you see this development in relation to the direction of community pharmacies?
Yeah, I think the key issue with community pharmacies is their, well, two things. One, their location, and two, their availability to the public. So we've done a lot of research in the past, which has demonstrated that community pharmacies are distributed geographically in order for people who maybe are less advantaged in socio-demographic terms to be able to access their services. And in fact, we have done research projects in the past which demonstrate that people who are from poorer socio-demographic areas actually have greater access to pharmacies. So that's a really strong message. Pharmacies are accessible to people who need them. And then secondly, of course, generally speaking, pharmacists are available without an appointment. They have long opening hours. Often the people working in community pharmacies, apart from the pharmacists, are from the local communities, sometimes able to speak different languages and relate to different communities. So I think from the point of view of accessibility, it's a really key issue. The next thing, of course, is that we do have poor rates of detection of cancer. We tend to detect it later in this country, and outcomes can also be poorer. So the question is, how many patients present at community pharmacies with early symptoms of cancer, or colorectal cancer in this case, maybe looking for treatments for symptoms, so things for diarrhea, for example, or for constipation, or for maybe other symptoms of bowel problems. And how could pharmacists and their teams intervene with those patients at an earlier stage, and perhaps draw attention to the fact that the symptoms that they may be experiencing are problematic or could be problematic. Equally, though, I think there's also a role in there for screening. We know that screening isn't taken up by everybody who is offered it. Why that is, there are many reasons that are well documented in the literature. I suppose community pharmacies reinforcing the message around screening, perhaps being in the business of supplying test kits within the framework of the current national testing system, which of course would require integration into computer systems, etc., would all be really important questions in my view. Pharmacists are very well-trained people. They are trained across a breadth of disease and a breadth of therapeutics. They are able to understand and to spot early symptoms of disease and also choose appropriate routes for referral. So where would patients be sent if, for example, they needed a screening kit? Could the pharmacist supply them? Could they be referred to the GP? Could there be a link to the screening service to attract sending out a kit? In terms of symptomatic patients, pharmacists, I think there's the potential to raise awareness with the patient or to think about more formal routes. So, for example, use of risk assessment tools and almost triage a patient who could then be sent to the GP or to whatever appropriate level of care would help the patient to move from the point that they are at.
Improving pharmacy skills and awareness in this field will involve staff training. Jessica Sheringham has developed a tool called eCrest to improve clinical decision-making and reduce the number of lost opportunities for early diagnosis. How could eCrest help this project?
When we developed eCrest, we did it in response to some learning from a study we did with GPs that found that when GPs had the right information, most of the time they made the right decisions on which patients to refer for further investigation to pick up cancer. However, in 40% of cases in our study, GPs didn't seek the right information. So they weren't able to make those decisions as easily. So eCrest was developed to help future doctors, final year medical students, to enhance their what we call clinical reasoning skills, what questions they asked and how they interpreted information about common symptoms that might be cancer. We initially developed these cases we developed simulated patient cases around lung symptoms. With Christian and his team, we've developed some cases around common bowel symptoms. These cases have been used not only by future doctors, but they are now being used by qualified pharmacists. So pharmacists taking an advanced prescribing course at UCL. And we think that these cases could be useful in supporting earlier diagnosis of bowel cancer for wider pharmacy communities.
Now I'm with Adam Todd, who's Professor of Pharmaceutical Public Health and the co-lead investigator on this project. How do we take this forward? What are your learnings?
Thanks, Stephen. So the project really confirms what we originally suspected, and that is that community pharmacists have a really important role to play in supporting people in terms of early detection for colorectal cancer. I think we've seen some really good practice already that's occurring, but I think really the project gives us some pointers in terms of how we can improve practice now. So things that we can implement at the moment to improve that role, maybe strengthen links to other primary care providers. So that will be really, really important, I think. But it also provides us for a direction of future research. So how do we conduct research to expand and improve the role of the community pharmacist in the early detection of colorectal cancer?
Finally, we return to the lead co-principal investigator, Christian von Wagner, for his overview of the achievements.
Okay, so when we started this project, there were a lot of uncertainties. And the reason why we've done this project and how we've done it through the use of innovative workshops and the way we've asked these questions was particularly because we didn't know what was feasible and what was acceptable. So at the end of this project, we probably still have many questions and many uncertainties, but clearly what we've also identified is a lot of enthusiasm and agreement that, yes, there are lots of things that community pharmacy staff can do to facilitate and promote early diagnosis of cancer. And it's not just us and the people who participated in our workshops. Clearly, there's also a lot that is happening on at the level of NHS England and other key stakeholders that, again, demonstrates that the question, is community pharmacy the right place to do something about early diagnosis of cancer, is very clearly yes.
Improving the early detection of bowel cancer is an effective way to bring down the death rates from this disease with existing medical interventions. However, it is clear that this challenge does not have simple solutions. By working with key stakeholders, this project is pointing a way forward, with recommendations and practice guidelines to develop the role that community pharmacists can play in achieving this important goal.